Okay.
Hello. Good evening, everyone. Welcome to tonight's Berggruen Seminar 6, entitled Ethical Challenges in the Use of AI in Precision Medicine. It's a great honor to moderate this seminar. I'm Haidan Chen from the Department of Medical Ethics and Law, School of Health Humanities at Peking University. Today we will have Professor David Magnus with us. Let me briefly introduce Professor Magnus. He's from the Stanford University, where he is director of the Stanford Center for Biomedical Ethics and a member of the Ethics Committee for Stanford Hospital. He's the former president of the Association of Bioethics Program Directors, and now is the editor-in-chief of the American Journal of Bioethics. Is there anybody have heard about American Journal of Bioethics? This is top one bioethics journal in the world. So he has published articles on a wide range of topics in bioethics, including research ethics, genetics, stem cell research, organ transplantation, end of life, and patient communication. And he was a member of the Secretary of Agriculture's Advisory Committee on Biotechnology in the 21st century, and currently serves on the California Human Stem Cell Research Advisory Committee. And he's the principal editor of a collection of essays entitled Who Owns Life? And his publications have appeared in the internationally top journals such as the England Journal of Medicine, Science, Nature Biotechnology. And he has also appeared on many radio and television shows. I will stop here, and let's give a warm welcome to Professor David Magnus.
Thank you so much for the kind welcome and the kind invitation. I will hope that I will not talk too fast. Let me put this down. I'm not sure I need this. Can you tell me, can everybody hear me? Okay, I will try and talk very loudly. It might slow me down a little bit. I have a tendency to talk fast, so I will try not to talk too quickly. So again, thank you very much for having me here. Precision medicine is obviously something that's become very, very popular and gotten a lot of attention. In the United Kingdom and Great Britain, they've got something called the 100,000 Genome Project. In the United States, there's the Precision Medicine Initiative, which was created by President Obama, and the goal there was to recruit 1 million people who will all be sequenced and have a lot of their data, their electronic health record data, lots of their data made available. In the interest of disclosure, I'm the vice chair of they call them in the United States, they call them IRBs, Institutional Review Boards. But we call it the Research Ethics Committee. So I'm vice chair of the Research Ethics Committee for the NIH Precision Medicine Initiative. So I have to oversee all of this and review all of the protocols. It's a central IRB, a central Research Ethics Committee, even though it's spread around all the country. But all of that is dwarfed by the potential for precision medicine here in China, with a potential for just much, much larger populations combined with significant investment and growing capacity to do sequencing. High throughput sequencing means that there's the potential for even more data, and especially for rare diseases that really don't occur very frequently. There's the potential here in China to find enough people with those rare diseases to have tremendous insights that really are not really obtainable in any other similar kind of research program in the world. So that's really the interesting thing. But the one question with all this enthusiasm is why? Why are we interested in precision medicine? And I think it really comes from the limitations of current physician practices. Physicians are limited in the number of variables that they can take into account, limited in their experience and what they really can use for basing things. The data that they've got is usually limited to snapshots. They see the patients when they're sick. They see them maybe for a yearly checkup, so they see them here, and it's just a snapshot, whereas what we really want is continuous data, a continuous stream of data. And then there's biases in what physicians do, and I study some of my studies study a number of these different biases, and that causes other kinds of problems in clinical practice. So the solution to these problems really lies in precision medicine. Take large amounts of data, people talk about big data, large amounts of data from genomics, proteomics, metabolomics, from electronic health records, from wearable technologies like, I'm wearing a Fitbit, but smartwatches, smartphones, mobile phones allow you to have a continuous stream of information that winds up being combined. And then with that much data, no human can possibly study and understand that. So it's going to really require artificial intelligence to be able to analyze that. Just to give an example, and this is based on work that's been done at Johns Hopkins University. When a patient presents for palliative radiation, some patients die within 6 months, some live for a year, and some live for several years. What you would like ideally is for the patients who are going to die soon, don't make them sick with radiation, really focus on their comfort. For the patients who might live a year, give them some radiation, but maybe not as much. And for the patients who have the potential to live for several years, you want to be much more aggressive with the radiation because it's worth it to make them sick for a few months in order for them to enjoy those couple of years. The problem is physicians are terrible at prognostication. They're terrible about knowing who belongs in each category. Machine learning can do better. And in fact, at Hopkins, they've now developed a much more accurate algorithm that can tell which patients belong in which category. And there's the potential for similar guidance in a whole range of things. Who should be prioritized for organ transplants? Which patients should be sent to the ICU? Which patients need more help and need more resources for coordinating their health care? All of these are things that algorithms can or are already doing. Now, when you think about the data at a fundamental level, there are two very different sources of data. There are what are called research repositories. So the All of Us research program is a research repository. In research repository, participants typically opt in to be part of those studies, and so informed consent is actually part of that, and genomics is usually an explicit part of the consent process. They often make use of clinical data, but because they are giving consent anyway in these large research repositories, that's usually covered by the consent. The other large projects are just using secondary uses of clinical or public health data. This is going to be a topic I'm going to be covering tomorrow. So for anybody who's going to be at the topic my talk tomorrow, I'm going to be talking about that. But today I'm really going to be talking primarily about these large efforts to develop research repositories that are being developed. And the US program, this is sort of the approach that this was going to be something that was promised to be a partnership between patients and physicians, not just human subjects, and that patients would even be able to help guide the research. But in order to be able to analyze the data from this large research repository, we're going to have to use AI, and I think there are some real problems and challenges with that. So I'm going to talk about 4 major challenges besides privacy and security, which I'm not going to really talk about today. There's ways in which there are values embedded in the algorithm design. There are biases in the limitations and the data, and I'm going to spend most of my time talking about that because in the US context at least, there have been huge problems in the data that's been collected in research repositories and that is available for research uses. There's a potential for misunderstanding and misusing these things. And then if I have time, I'll talk about the significance for the ethics of medicine, but I probably won't have time to get to this point. So values in algorithm design, what outcomes are being optimized, how are variables being weighted. In the US, at least, a lot of these algorithms are being designed by third-party vendors, commercial entities that are then selling them to healthcare systems. The interests of healthcare systems and the interests of the designers may not be the same as the interests of physicians and patients who will be using the results of these things downstreams. So you can imagine that a healthcare system might not just care about health. They might want to know about ability to pay and whether you're going to, and how much money you'll get from that particular patient in making decisions about their care. There may be quality metrics that may not correspond to concerns of patients or physicians. But I'm going to spend most of my time really talking about biases and limitations in the data that algorithms learn from, and especially about this problem. In the US context, we just don't have a lot of the data we really need from groups that are traditionally underrepresented in research. So this is the problem: the Eurocentrism of these databases, of genome-wide association studies. In the US, this is what our data looks like. No African Americans, no Hispanics, no Asians. It's just all white people. And in fact, this is a problem for the whole world. If you look at GWAS studies, genomics for the whole world, my colleague at Stanford, Carlos Bustamante, and some colleagues studied. This is from a handful of years ago. At that time, the whole world genome-wide association studies, 96% of the genomes that had been collected for data were for people of European descent. Everything else, only 4%. In 2016, a study looked at whether it had gotten better. That other study was from 2012. 2016, it had gotten a bit better. It had gone from 96% to 81%. And by far the biggest difference is including many, many more people of Asian descent. But all of that is being done in Asia, in China. In the US, even though we have Asian populations, they're not being studied. African Americans are not being studied. Hispanics are not being studied. So if populations are systematically underrepresented in these studies, then artificial intelligence systems will be unable to accurately make predictions that can benefit those populations, right? And socioeconomic, in addition to diversity with regard to race and ethnicity, the same thing applies, especially when you're thinking about all these large amounts of data, about socioeconomic diversity. Because if you look at who's included, it's not just white people, it's affluent white people. And people who are poor are not included. People who are illiterate, especially, are not included. And that's a real problem. If you want to do a great job of predicting health in the United States, you can do it by zip code. It's an incredibly powerful predictor of outcomes. People who are living in rich areas live much longer lives and live healthier lives than people who are poor living in poor areas. So how are we going to solve this problem? How are we going to fix the data so that it's more representative of other populations? And to do this, I think we have to understand at least some of the obstacles to recruitment. And what I want to do now for a while is talk to you about some of the studies that we've done to better understand some of the obstacles that are stopping these underrepresented groups from being included in research. And I'm going to talk about three particular aspects of some of the studies that we did. First one is that the language that we use matters and makes a big difference. Second, what I'm going to call biospecimen exceptionalism, the concern about the samples themselves as opposed to how people look at data. And then last, I'm going to talk about some value differences between these different populations. So this study, or set of studies, really, we call this the value study: patient values and attitudes about a library of knowledge, uses of electronic health records and samples in research. I really like acronyms, and I've rubbed off on all of my colleagues, so we come up with all these different acronyms for almost everything we do now. And these are the two aims of the study. We wanted to assess and compare patient attitudes towards use and governance of clinical data and samples in a racially and ethnically diverse patient population, and identify the factors associated with attitudes and preferences towards clinical data and sample use, sharing, and governance. Now, this is a multidisciplinary, multi-institutional collaboration. This is the research team at Stanford. We had a group from Palo Alto Medical Research Foundation who were helping us recruit patients for this. Ben Wilfond and Stephanie Alessi, one of our former postdocs at the Children's Hospital. We had a group of people who developed videos as part of this project. and this was supported by a grant from the National Library of Medicine. It's a mixed method study. We spent a lot of time doing video development, and we developed a bunch of video trigger films. So we had a bunch of short films about 3 to 5 minutes in lengths that are illustrated videos to explain key concepts. Then we did, using those videos, we did focus groups with diverse racial and ethnic populations, and we're now in the midst of actually a randomized trial and survey. So the data I'm going to be talking to you about is all derived from all these focus groups. So we did 20 focus groups of Palo Alto Medical Foundation patients, 4 African American focus groups, 4 Chinese focus groups. 2 were done in Chinese Americans who speak English, and 2 were done in Mandarin. We did 4 Hispanic Latino populations, 2 in English, 2 in Spanish, 4 white focus groups, and 4 South Asian focus groups that were all done in English. Total, there were 122 participants. We developed a code book doing standard content analysis, partly deductively derived and partially inductively derived code book. Each transcript was coded by an additional team members. All coders achieved inter-rater reliability greater than equal to 80%. And it was team-based thematic analysis for the themes that I'm going to be discussing. So the trigger films that I mentioned, these are the topics of the films that we had. One was to just talk about this new model for research using all of this data. We called it the Library of Medical Information, and I'm going to talk about why we called it that. Value and precision medicine, privacy and security. And then we talked about disclosure and consent, oversight, and patient communication. So these are all the videos that we developed as part of this. Okay, so this is our first paper that came out of this, about metaphors. And one of the things that was really interesting to us when we first started to think about it is, how do you describe what this research is about and what these research repository are? And it's hard to talk about these things without using metaphors and without using language. And metaphors are all examples of what's sometimes referred to as indirect speech acts. A very different area of study of mine, I study communication between patients and physicians, and I use some tools from linguistics and linguistic anthropology to study these things. But it turns out saying more than we literally than the literal meaning of the words is a ubiquitous feature of language. So it's just something that happens all the time, often without us even knowing it. Do you know what time it is?
6:50.
So I asked a question. You did not answer my question. I asked if you know what time it is. The answer would be either yes or no. But instead of saying yes or no, you told me what the time was. Now, the reason why you did that is because there's no reason why in the middle of a talk why I would want to know the state of your temporal knowledge. But I might want to know what the time is. So you made an inference about my intention behind what I said. And we do this all the time so that we don't just pay attention to the literal meaning of the words that we say, but instead we often make inferences about what the meaning behind these words are and the intentions behind these things. But that works great when there's enough that's shared for that to work. But the more there's not a shared understanding, the more that can go awry in different ways. And we were very worried that patients or the public, research subjects, and the researchers who are doing this research come from such very different backgrounds that the language that seems simple and metaphors that seem to work very well for the researchers may convey things unintentionally that maybe lead to misunderstanding when the participants are hearing the uses of those language, and that there may be, in the language of linguistics, there may be unintended perlocutionary effects from doing this that could be actually very important and significant for the recruitment of especially these underrepresented populations. So we started to think about the language, when people talk about these projects, at least in English, they often use the word biobank and describe these things as biobanks. which is an interesting metaphor with a lot of different things. But there are other languages and things that could go behind it. And when we started talking to people in these focus groups and in preparatory focus groups, we started to see a lot of different valence and attitudes about these different metaphors. The banking metaphor is kind of an interesting one with an interesting history. In the 1930s, the researchers were just starting to develop the ability to preserve blood, and they were doing research on preserving blood in the hope that they could then give blood to patients later. And in the US at least, they call these things blood banks. But that was a decision that was made in 1937. Before then, it was called the Blood Preservation Laboratory. But they were worried that nobody would donate blood to the Blood Preservation Laboratory, so instead they decided to call it the Cook County Hospital Blood Bank. And changing the name was useful for them in being able to recruit more people to be able to donate them, and the idea of a biobank and then later a tissue bank and an organ bank really came out of this marketing decision, essentially, that was made in 1937. So when we talked about alternatives to banking, because one of the things we quickly found was in many of our groups, the notion of commercial aspect of banking had negative connotations. And so biobank actually was not something that some of the folks really liked very much. So we looked at other possible metaphors, a pool, a reservoir, and here are some of the good things about using a reservoir as a metaphor. We could call these research reservoirs, or a library, and maybe this was influenced partly because my wife, who's here today, is a librarian. We looked at some of the advantages of thinking about a library as a metaphor, and that's what we wound up using in the end, the library of medical information. We thought that this might be a useful way of conveying information. And then we had these, the library metaphor, libraries store information and knowledge. They are used for research. They're a public good. Community members voluntarily contribute to the library. Books can represent individual records or samples. Once donated, the book is owned by the library, and librarians control access to the library. So we thought this would be a good metaphor. And then those trigger videos that I mentioned, this is sort of what it looks like. And you can see these are electronic health records data going into the Library of Medical Intervention information. And in the videos, they sort of pick them up and move them over there. And then these are same thing idea with samples that are moved over there. So both samples and data are in the library. And then we talked about some of the other examples about the security in the library, for example. One of the things we quickly found out was this did not work very well in Chinese. And I can't even begin to translate some of the words that you'll see in a second. But we found several challenges that we heard from in our focus groups. The translation of written language, simplified Chinese, to spoken Chinese, because these videos had both written and spoken at the same time, didn't cohere very well. And the literal translation of the English text did not make much sense. And spoken Mandarin does not back translate directly into the original literal English. We also found some regional variation in language and terms, making commonality harder in our Mandarin focus groups. So translation of the library metaphor into Chinese, I don't know how to say this, there we go. The literal translation of library meant a physical place set apart to contain books, periodicals, and other materials, which didn't really translate very well what we were trying to convey. Instead, what all the people in our focus group said is that this is really what we were trying to get at and is a much better metaphor. A database is a much better metaphor. So whereas in the US, a biobank is not, we don't think, a good metaphor, even though it's common. We think a library is a better metaphor. But in Chinese, a database is a much better metaphor for conveying this than it is. And you can see that there are differences between these things. So we found that much closer to the concept of the Library of Medical Information than a literal translation. And when we asked people, what is the Library of Medical Information, most of our Chinese participants said database, either in Chinese or in English. So, but all these choices of language carry with them implications. They carry implications both for conceptual accuracy of what's being conveyed. So when you use the banking metaphor, it really emphasizes the samples, the physical samples, when you talk about a biobank. On the other hand, it doesn't convey that data is going to be conveyed. In contrast, when you use a database, that really conveys that there's data being conveyed, but it may not convey as well that there are samples being conveyed. And then we also found that there were valence, there were actual value associated, positive and negative value associated with different aspects of these different choices of these metaphors. So these metaphors really matter in the way that we think about these things. And we really want to make sure that when we do this, we want to avoid exacerbating biases. And in just a minute, you'll see why I think metaphors like biobanks that are commonly used in the US may inadvertently make people who are minority populations, underrepresented populations, less likely to participate in research. And you'll see why of that in a little bit. And in any case, really paying attention to our language is going to be really important. Interpretation of the concept may change the understanding, the perception of the function, risk, benefit, and there need multiple methods to revise, retranslate behind literal words. Okay, I want to talk about the next thing that came out of our data. I don't want to be Henrietta Lacks. I don't know if anybody here knows who Henrietta Lacks is. So there's a very popular book in the US about this. She was a poor black woman whose cells wound up being incredibly widely utilized. They're the most utilized cells in the world. I don't know if we have any scientists in the room, but if we did, I'm sure all of them would have heard of HeLa cells. HeLa cells is short for Henrietta Lacks. So her cells are now used in labs all over the world. But she had no idea that this was true, neither did her family. And a reporter wrote a book in which she interviewed all these people and really uncovered her story. So anyway, this was a quote from one of our people in our focus group. I don't want to be Henrietta Lacks. And this was a study where we really wanted to look at, most people just assumed data, samples, same thing. They usually lump them together into these repositories or banks or libraries or databases. But we wanted to see if people looked at them differently, and especially across these different racial and ethnic groups. So we probed to see would they feel about their electronic health record data being used for research that was explained in the videos, and then asked how they would feel about their biological samples being used for research. And those samples could then be used for doing genomic or genetic analysis. Genome sequencing, exome sequencing. So one thing, a lot of people said they didn't see any difference and there was no difference. So I have no problem with the tissue samples or the blood. To me, it's the same as the data. So in 19 of the 20 focus groups, at least one person in those focus groups said, I don't see any difference. But we were surprised to see that there were actually other people who saw significant differences. Some people saw biospecimens as extensions of the self and require special care and respect that make it different from data. And this is a quote from one of our South Asian focus group participants. I feel more uncomfortable with giving a biological specimen because it feels like an attachment or extension of myself. A blood sample or tissue sample feels connected to me, and that makes me feel more vulnerable because that was a direct piece of me versus a reaction to me. And then I think of the example of Henrietta Lacks, and I'm like, I don't want to be Henrietta Lacks. Right? 9 of the 20 focus groups I expressed similar kinds of sentiments, that this is a piece of me and matters. But what's especially interesting here is 0 of the white, this was not expressed in any of the white focus groups. We saw that in the underrepresented groups, but not in the white population at all. There was concern that biospecimens are sources of unjust profitability. If they're going to pick 50 samples and you happens to be one of them and they discover some world-saving drug and they make $1 trillion, where's your share of that because you helped to do that? And actually, if you actually break this down, these populations were concerned about the unjust profitability making drugs too expensive. The white populations all were concerned about getting their share. But we didn't see that expressed in any of the other groups. There was also worries about privacy. All groups were concerned about privacy, that this might be a problem. And they worry that there's more of a loss of privacy for samples than there is for data. That's not true, but people believe that it's more risky more of a risk for their samples than it is, and all of the focus groups express that concern. So biggest surprise to us, 8 of the 20 focus groups brought up human cloning. Can you make another me out of that? I don't want that to happen. I don't want that to happen. And again, that was something that we saw in 8 of the 20 focus groups. Again, none of the white populations had that concern, only the other populations. And whether or not there might be separate consent for biospecimens versus data, 12 of the focus groups thought that made sense. I would say yes, I'd like to separate the consent processes. I couldn't separate bio from just electronic health record. I don't think I would participate. If you couldn't show me 2 different consents and explain these things differently, I would not participate in the research. So obviously there's a challenge for going from mere opinion to policy development, and all these findings are qualitative, so there needs to be more follow-up. But interestingly, some of those concerns suggest we need to do more education because they're clearly misinformed. But there's a suggestive pattern of other concerns that suggests that there might be differences that can matter for recruitment of underrepresented groups in research. The quality of the concerns about samples were different in the underrepresented populations compared to the white populations. So that's something that I think we need to pay attention to. I'll just say one other thing why that especially matters. It means if you're using, and this relates back to the metaphors, if you're using a biobanking metaphor that emphasizes the samples, the fact that these underrepresented populations have these extra layer of fears on that means that choice of metaphor is likely to lead to underrepresentation in those populations. And so choice of the metaphor ties back to the fact that these groups have fears of samples over and above their data. So the use of the word database may actually be beneficial for recruiting some of these populations. Okay, then there's differences across the groups that we saw in terms of values. And I'm going to talk about four different sets of themes. So first, there were very different expectations of benefit in these different focus groups. Patients who identified as white expressed greater confidence than other groups that this type of research would improve their health care. The benefits are so enormous for everyone that, there's no downside. This is huge, a revolution in medicine. So the white populations all saw this as beneficial. In contrast, the other groups expressed experience of discrimination in healthcare that produced skepticism about benefiting from research. I know that historically there have been tests done on our population that's been secretive and hasn't been to our benefit, so it could be some seeds of that still in my memory bank somewhere. There was fear of population profiling, fear that potential findings will be used to justify discrimination, and that certain racial and ethnic groups will be associated with disease, or that racial stereotypes will be justified by the findings. The Asian groups raised concern about the research leading to more expensive treatments. All groups except the white ones were concerned about government uses. So certain ethnic, religious, cultural groups were targeted for certain hate crimes or with certain countries due to certain different types of demographic groups, like as far as exploiting them or treating them differently or not treating them fairly. It's like that information is giving that government agencies more substance how to attack a certain group or how to discriminate a certain group. So the white populations were not worried about this, but all the other groups were very worried about this. And they're going to require reassurance if they're going to be participating in this research. Unfamiliarity with the healthcare system. We found the Hispanic, Chinese, and South Asian focus group link a lack of trust in research with general unfamiliarity with the U.S. healthcare system. So people who tended to be more recent immigrants were concerned about the whole healthcare system that they're being exposed to. The whole medical system here, the whole ecosystem surrounding medicine, with insurance and everything, is very difficult for someone from our system to navigate through. They're not used to that back home. And that automatically creates a lack of trust, like she said, knowing that you could in effect be denied treatment if you have a medical condition because of economic reasons. Most nonetheless supported the idea of participating in research, particularly if there was trust established. The importance of engagement and recognition of cultural differences in building a trustworthy enterprise. So the importance of engagement and recognition, all except the white population emphasize the importance of addressing cultural differences when communicating information about research. We have to keep reaching out to be culturally sensitive, have more culturally competent researchers, and you know, the way you frame questions, it's extremely important to be sensitive to cultural groups and to slowly build up that trust and confidence in the system. And I think it also helps when there are more researchers who are from different cultures, you know, like people who are doing the outreach itself. When they can identify with the people, I think there's a higher level of trust. So it's very hard when it's all white people who are the researchers going out there and trying to recruit people from these other groups. It's really important to partner with those communities to build trust and build ties with those communities. I have family that's in Atlanta, Georgia, and they have 2 great medical facilities in Atlanta, but the African Americans still go to Grady. They will not go to Emory. Emory is the big university hospital. Am I lying to you? They will go to Grady because that's where they feel comfortable. So when it feels more like it's part of your community, you're more likely to participate. Consider who is doing the asking, whether researchers or other recruiters are from the community. So you being Caucasian, going to an all African American audience would get a different reaction, would get a different acceptance level, if you will, versus an African American, a known African American doctor, somebody who would be trustworthy. Guarantee it. I think that people relate to people that look like them. They trust people that look like them more. And cultural norms matter. A number express different views about the use of their data versus the specimens, as we've already said. You cannot donate with the expectation of getting money, and so I think there'd be a ruling saying if you're going to donate a sample of yourself or a piece of yourself, it could not be in exchange for money. So that was a very interesting view. In contrast, whites raised concerns that others might profit from their material, and then we already saw that quote earlier. Okay, all of that is just to show that we've got a huge problem with missing data. And if those populations, if we can't fix that problem of getting them represented in this research, then AI is going to be biased. We're going to learn different things. And precision medicine is going to be medicine for rich white people, in the US at least. And hopefully that will have some lessons for how to do this well in China. I'm going to now just talk very briefly about biases in the data that can lead to self-fulfilling prophecies. So this is some other research that we've done where we've done surveys of transplant programs, pediatric transplant programs, and we've done a lot of surveys of transplant programs. We have a lot of interesting data coming out right now that actually from some other studies. But this one, which we published a while ago, you can see that 33% of programs always or usually use neurodevelopmental status as a consideration. So when kids have what's called neurodevelopmental delay, when they're cognitively not normal, 44% of programs always or usually use it, 39% of programs never or rarely use it. And you can see that 40% of programs never use it as an absolute contraindication, and yet 4% would say even moderate would be, 21% would say severe, 19% profound. That means 44% of the programs would make this an absolute contraindication at least some level, while 40% would never use it. So the very same children who show up at one hospital will get a transplant. If they show up at a different hospital, they will not get a transplant. The reason why that's significant for machine learning is machine learning learns from the actual outcomes that happen, and it's blind to the causes of those outcomes. So if you're developmentally delayed at a hospital that won't transplant these kids, it's just going to see that developmentally kids delay all die. Well, they die because you didn't give them treatment. But the machine learning that's learning on the outcomes will just see these differences in health outcomes. And there's the potential for this to reify and reinforce existing inequality. It will tell the doctors that they were right not to list them because, look, they have terrible outcomes, right? But those outcomes are a function of biased decisions. And I say biased because the data shows that the outcomes for transplanting developmentally delayed kids are just as good as the outcomes for non-developmentally delayed kids. Okay, and then of course there are accurate differences in health outcomes that can be a function of social injustice, and this creates a real dilemma. right? Real differences in outcomes correlate with social determinants of health. Machine learning will learn these traits, predict worse outcomes. It will be more minorities and poor in less than 3 months, right? So that first example where I said, let's bin the patients, if you look at clinical healthcare outcomes, it will say the patients who present for palliative radiation, who are likely to die in 6 months, those are going to be much more likely to be African Americans. It's much more likely to be poor people. Where the ones who are likely to live longer are much more likely to be rich white people. And so, and that's just a reality. And so all the health wealth gradient that produces excess death in poor populations, racial and ethnic health disparities that produce excess death in those populations, all of those lead to excess deaths. That's going to be captured in any kind of data that actually looks at outcomes that are health outcomes. But we could try and ignore that, and there are some efforts to do that or look at alternatives, but that can have other problems. There was an article that was published about a week and a half ago in Science where they actually were able to open up an algorithm, and it actually demonstrates two things, and it's kind of an interesting study. It demonstrates the difference in these health wealth outcomes that I'm describing for you, but it also demonstrates the ways in which values influence decisions that are made in algorithm design. So this is a very widely, so these guys are studying a widely used algorithm to predict which patients are likely to be so sick that they need to be enrolled in special programs. Who needs some help? Who needs more resources? So this algorithm is commonly used in healthcare systems to predict who needs more help, who has chronic health conditions that make them need more health. Now, what this shows is that when you fix for what the algorithm predicts for risk factors, so who should get into the program, you can see that African Americans are much sicker than white populations across a bunch of conditions. This is diabetes, hypertension, bad cholesterol, renal failure, and anemia. This is a huge difference where there's differences in the health of these different populations, African Americans. They're sicker at the same level of the prediction. Now this is bad. Let's see, and this just gives you the overall way of looking at it. This was bad because it's accurate, right? That there are those differences, but the algorithm didn't see those differences because the algorithm didn't look at health. The outcome that looked at cost. And it turns out that if you base it on cost rather than on health, you wind up systematically misleading in your risk assessments so that sicker black people are seen, black people have to be sicker to get those resources than white people. Now they opened up and cracked this open and figured out how to correct for that by essentially focusing on actual health outcomes rather than costs. They could actually get something that was much more accurate and would get African Americans into these valuable programs that they're currently being excluded from. But in a way, there's a double-edged sword to that. This was saying you needed to be so sick that you would get into these programs, and because they were using cost rather than health outcomes, African Americans were being discriminated against. But for some other things, you might make decisions where if you're too sick, you won't get those things. That's the kind of thing people do in transplant listing decisions, for example. And what this shows is that for some of the same factors, the fact that African Americans are sicker means they won't get access to care for any algorithms looking at those sorts of things. So the same algorithm they have that fixes this problem will make things worse when similar kinds of fixes are used for other things. So I think that's actually going to be a really big problem with the study that these people have done. I just really thought this through while I've been here in China because I've been mulling through this data. So I'm going to actually write this up. And I know the lead author in this, so I'm going to talk to him about why I think this may be a problem. Okay, then there's the misuse of algorithms, and I know I'm getting low on time. So, okay, so clinicians in health systems may not be aware of data limitations. Physicians in health systems may not be aware that there are these value decisions that are embedded in the algorithm. Algorithm results may be applied to individuals and populations where it's not as predictive because they're underrepresented in research. So what are some solutions to all of this? The first one I should say is this one. We need to reduce disparities in the data. That's why we were doing all those studies I talked about earlier. We need to make sure that we get these groups that are right now being left out and get them into the studies. I will say, I think the All of Us research program has learned from our studies and other groups who have done similar studies, and they've learned that they need to use communities to do the recruitment. And I will say that so far, the early results of the Precision Medicine Initiative are very promising. Right as of today, about 16% of the recruited participants are African American, about 17% are Latino, so it's looking like they're doing a better job. We also need much more transparency in the algorithm design process. That Science article was only made possible because unusually the people who developed that algorithm are willing to essentially open up so that people could really look at it, not just look at the inputs and the outputs, but really crack open the algorithm and understand why it was working the way it was working. We need much closer collaborations between clinicians and engineers. It's shocking to me how little interconnection there is between physicians and the computer scientists and informaticists, the engineers who are designing these algorithms. Most of them don't know anything about medicine, and instead of working closely with physicians, when you talk to them, they say, when I try to talk to physicians, I talk to 5 physicians to get advice, I get 5 different answers, so instead they just look it up on the web, and that's how they're finding out their medical information. That's not a good situation. And the need for awareness of the values and interests in the algorithm design process, which is not an easy thing, but it's absolutely imperative. I'm going to just end here with one final take-home point, because I think I've been talking to you enough. Large amounts of data plus machine learning are very powerful tools for precision medicine. But at the end of the day, they are just observational studies prone to all the biases. Machine learning algorithms learn on a training data set. When they're applied to new situations, they don't necessarily operate as well if there are discrepancies between this new data and the data on which they learned. If you talk to anybody who really works in this, they know all kinds of problems that can emerge in the algorithm design process and that can arrive leading to biases. And at the end of the day, they have all the limitations of observational studies. In a very famous study that was done at Pittsburgh, they wanted to understand when people get the flu, who needs to be hospitalized and who doesn't. When they developed their algorithm, machine learning found a very powerful predictor of who needs to be hospitalized and will be sick and who does better. And it turned out the people who did better were people who had asthma. Well, being asthmatic is actually not good. We know that's not good for you when you have the flu. But the machine learning said that it was. Why is that? Because at the end of the day, it's just an observational study, and it just so happens in the data that they had, then that's what happened. There are lots of possible explanations for it, and why it went wrong, but that sort of thing happens all the time. At the end of the day, we still need to go beyond this, and we still need controlled trials and data to really know and really control for variables, and can't just assume and overly reify the results of machine learning on big data. Machine learning on big data is great, but it's not by itself going to answer a lot of questions that require controlled trials. And that's it. Thank you very much. Okay.
Some water. Okay. I'm not sure whether you have followed him all the way from the very beginning to the end. So I will translate briefly and some background to the students in Chinese.
Okay.
And then followed by Q&A.
Okay.
实际上他讲的东西特别多啊，然后我就大概归纳一下。可能我还得看着他的 PPT， 然后把主要的要点跟大家分享一下。就是我们可以从最后的那个他的 take home message， 就是他的报告大概的主要的想要传达的意思是什么呢？他刚才也讲了，就是说，英国也好，美国也好，其实中国也好，就是在最近几年都在大力推动这个精准医学计划。甚至在美国的话，他把原来是叫 Precision Medicine Initiative， 把它的名字都改成了叫做 All of Us Research Program， 就是 All of Us， 所谓的 All of Us 就是说所有的人都应该参与到这个精准医疗这个计划里面来。为什么呢？它就是现在就随着这个基因组学的 发展的话，就是说这个基因组学它，因为每个什么叫精准医学，可能我不知道需要这么具体讲吗？还是说大概的需要你们更多的背景吗？比如说你们对精准医学有了解吗？比如说人工智能，需要我讲的更具体吗？还是就简单的把它简单的就行了是吧？具体一点是吧？So they want to detail about precision medicine, the machine learning, and so I will explain in Chinese. 就是精准医疗计划，就是为什么美国或者是中国是英国要推出这个精准医疗计划呢？就是说，我们以前就是比如说感冒或者是癌症治疗，就是所有人都是一种治疗方法，要不然化疗什么放疗。但精准医疗的话，它精准医学的话，就是说不同人根据你的基因组学的特征，然后去研究，就是针对不同的人群，特别哪怕比如说你是非洲裔，或者是说拉丁美洲的这样一个人群，它的可能那个基因可能是有它的特异性，所以呢，它的治疗方法也是不一样的。所以但是呢，就美国的那个精准医疗为什么要 Oral VAS？ 就显然就是他刚才在他的数据里面也给我们看到这个 GWAS， 就是全基因组关联基因组学研究。那么按理说是应该把全球的就是特别是美国的各个基因组、各个人群都有代表性样本都纳入到这个 Oral VAS 这个研究计划里面去。但是我们刚才从他那个研究当中也发现说，其实只有在他的这个 GWAS 研究当中，大部分都是欧洲人，或者就是美国人，他就是白人、黑人，就是这样的，就把其他人种都给排除在外面了。那这样实际上他这个数据就是有 bias 有偏差。所以它实际上这个研究，一般人都说，精准医疗很好，我们全球各个国家都在推动精准医疗计划。那它的研究事实上从一种 critical view， 就是一种批判性的思维去看这个精准医疗它背后存在哪些问题。那么它核心想要讲的就是说，这个精准医疗，特别是精准医疗有这么大的大数，就是说它传统的这个基因组学研究或者说这个临床实践当中的这个短板是数据太少。那么现在我们有大数据，而且现在我们可以用人工智能的方法。两者结合起来，那么更推动的就是对这个基因组学研究会更深入了解，然后更有利于这个临床决策。但他的研究就只是说，哪怕我们有精准医疗计划，我们有大数据，我们有这个人工智能，我们有这个深度学习这些各种各样的工具或者是手段，但实际上它还是很有限的。那么他在他的报告当中主要就是想说，光是这些东西是远远不够的，我们还需要一些传统的方法，比如说临床试验，然后临床这个叫做对照研究，然后还有就是说，它主要是想要说，我们这个在我们的观察性研究当中，还是有存在着很多的局限性。那么它主要是想通过3个研究来，它主要说的是，我坐下来行吗？我想看着它的 PPT， 因为我实在记不住东西太多了，那么它主要是讲了3点，就是它主要是讲是说。现在的局限性就是这个数据大数据有4个主要的伦理挑战，包括隐私和安全。那么它今天的报告的主要内容是在讲着数据偏差和局限的问题。那么这个问题就是，所以他想就是我看看啊，我记录的东西也是有点乱。它主要是讲，从3个研究来讲，第一个研究就是在讲说特别是在美国，他们做的研究就是说没有被代表这个人群的数据的缺失这个问题。那么这个问题，它是通过他们自己的这个 focus group study 就是焦点小组座谈的研究方法，来对这个问题进行深入的探讨。那么另外2个研究就是 bias data， 就是说在数据当中存在偏差，可能会导致这个有些科研人员他不知道他数据偏差这个问题，没有意识到这个一些没有人群、一些特定的人群、一些特殊人群没有被纳入到他的数据里面去，他就自己都没有意识到说他是这个结果是存在偏差的，没有进行正确的这个 prediction 是预测哈。那么还有一个就是说，就是因为这个一些特殊的人群，一些所谓的弱势人群没有被纳入到他这个研究当中去的话，就产生了一种社会不公正。就是按理说，这个贫穷人群他们可能是应该得到更多的医疗救助，然后就是其实我们在医学社会学、医学伦理学当中谈论更多就是所谓的弱势人群。那么我们看一个健康结果来讲，说这个弱势人群或者一些比较偏远贫穷一些没有代表不是什么所谓的白人、黑人这样主体人群的话，那么他们的生活状况，什么他社会地位都比较低，那么导致他这个死亡率会更高。所以说，但这些东西都没有被纳入到他们现在的这个大数据研究，也没有纳入到人工智能跟精准医疗结合的这样一个研究。就大体就是，我是想他这个报告是这样。
然后我想具体讲一下，就是他刚才介绍比较多的就是他们团队在用焦点小组座谈去探讨这个在美国的精准医疗，就是All of Us 这个 research program 里面的这个没有代表人群，为什么他们没有被纳入进来？背后的原因是什么？为什么这些人那么难以招募？因为刚好我是在2016年到2017年，我是在他的就是斯坦福大学生物医学伦理学中心，就是福来头访问学者，所以我刚好在他那个中心访学。然后我在他访学的时候，他们刚好在做这个研究，而且我自己的研究也是在做这样类似的在中国做的研究，所以我相对还比较了解一点。而其他研究它主要是就是在引用别人的一些，比如说 Science 那种最新发表的研究来再次佐证他自己的研究结论吧，我是这么理解的哈。那么他这个研究怎么做呢？这个我其实还比较熟悉，不用看都知道。就是我们知道说，无论是这个精准医学，这个我就可以正式来讲，就是那个这个精准医疗计划，我们说要不同的样本、不同的人群都要纳入到这个研究里面去。那么那些人为什么没有被纳入进来呢？然后他们就对这些没有被纳入进来的那个未代表人群进行这个焦点小组座谈。大家知道什么叫焦点小组座谈吗？就是说它是一种社会科学的研究方法。就比如说他一次招10个人过来，可能是不同的背景，然后来就同一个问题来看看，他会提一些问题，会有个引导者，然后不同提出问题来。当他的问题是设计过的，以他的这个研究目的去让那个参与者来回答他的问题。所以说呢，但是如果说像我们大家很多人是北大的学生，但是你们也未必知道什么叫 biobank， 对吧？那么对于那些这个特别是那些未代表人群，他们一般情况下可能社会地位啊、教育层次都比较低的。那怎么样让他们人来去参加？他们谈他对这个生物样本库的一些看法呢？包括他为什么不参加？他有哪些担心的问题？比如说你是不是考虑利益共享的问题啊，或者是隐私的问题啊，或者是你知情同意的问题等等。那么怎么样让他们对这个问题开始讨论呢？所以他们用的方法就是说，在开始之前，让这个参与者对这个 biobank 有所了解。但是如果讲 biobank 的话，他就会或者是 genetic database， 他可能就不理解这到底是什么东西，他们那个 database 都没听说过。所以呢，他们就有个比喻的，就 metaphor， 就是用比喻的方法，把这个 biobank， 或者是我们可以有不同的说法叫 genetic database， 把它比喻做这个library。然后呢，就给他们整部还看过这个视频，就他们把这个东西做成一个视频，然后给他介绍一下说这个什么是 biobank， 然后使这个参与者，就参与焦点座谈的人对这个生物样本是什么东西有所了解之后，然后才能引发他们对后面相继的一些生物样本库或者是基因组数据库相应的一些伦理社会政策问题的一个意见的表达。然后在这个之后，然后他就问他，然后他是主要是讲了4个，通过他这个焦点小组跟20个，他们做了20个焦点小组座谈，然后他主要得出了这个4个主题，就是这个一个就是说不同的参与者或者是不同的人群，他们对这个参与这个生物样本库有什么样的就是他不是说我谁都愿意去参加，他就说他肯定是想要从中能够有什么样的利益，也许是他个人的一些利益，也许是对这个科学整个基因组这个研究的一个促进，还有呢说就是他们会不会，因为他是本来就是特别，如果大家去过美国的话，会知道就是一些特别是黑人，就特别是他种族歧视问题嘛，所以特别就怕，如果说你这个白人科学家用我这个黑人的样本去做研究，会不会对我们这个族群会带来一些？就是说会有造成，比如说或者说你们生产药物会不会给我们特别贵啊，或者是会不会对我们这个族群的一些东西会带来一些伤害啊？所以还有一个就是说，他们通过这个焦点小组座谈也发现，这些参与者就是未代表人群对这个美国的医疗制度其实还是不是非常熟悉的。另外一个呢，他也是说，通过他的研究也发现说。为什么那些人群没有参加这个美国的All of Us Research Program， 是因为他们就是他们也意识到，就通过这个研究意识到应该让他们就是让这些未代表人群参与到这个精准医疗计划是非常重要的，而且呢就是要建立一种就是信任，也就是说。他们有各种各样的担心，那么怎么样在他们有担心的情况下，还使他们能够愿意参与到这个基因组学，就是精准医学计划里面来呢？他就说要这个信任很重要，让他们信任这个科研机构。我想，因为我也做过类似的研究， 我的研究就在中国就发现说，很多人很担心隐私问题，特别怕这个隐私被别人这个利用了会怎么样，对自己带来一些什么伤害。但是他们觉得说，这个参与这个生物样本库基因组学研究的话，一个方面可能自己会得到一些免费的体检啊，或者是做一个免费的基因检测啊，然后了解自己身体情况。另外一个方面也会推动这个基因组学的研究，然后最后将来会有利于整个人群的健康、公共卫生，所以他们也就愿意参加了。所以我觉得其实就他主要是跟我们分享这4个他的研究发现。大家还有什么问题你可以先问我，我觉得大概就这些，就主要就是他的结论是这个，他最后推出来就主要是通过这个自己的研究来，甚至是后面2个研究进一步来论证，所谓的精准医疗计划 all of us 题目就是说我们所有人都参加，但实际上是有存在严重的问题，很多样本没有被带掉。然后那些科学家、那些医生自以为说我的数据大数据，你看我这个结果是很核心的，但实际上他还没有意识到这个数据本身存在的一些问题。哪怕用什么深度学习、人工智能办法，这个本身这个短板是没法弥补的。所以说他也就是我在想，他也想说明，也就是通过这样的一个研究，也想说明以后我们在下一步的研究当中应该重视这个人群，让他更多这样的人群来参与到这个里面去。这一方面也是这个一个健康公正问题，对吧？使这个弱势人群能够享有更好的这个健康。I think I have talked too much.
Wow, I was very impressive. Yeah.
You know, when I was at your center, because Sandra and Chur, right? They shared with me your research project, and I did the focus group studies in China. Of course, I didn't use the video, but we have the survey, liquor, 5 questions to get the participants understand what biobank and their concerns of ethical, legal, social implications of biobanks in genetic databases. So, okay,
Interesting.
So the floor is open for questions, and I do encourage everyone with questions. Challenging questions for this very famous professor.
Yes, let me start. I don't think.
Okay.
So when you change the name, precision medicine initiative, change the name to all of us, just because you already noticed that the population is some population underrepresented.
That's interesting. So they did. There's several things that are unusual about this project. So I didn't talk about some of these aspects of it, but there's several things about this project that are very unusual for a research project. Yeah. So unlike most research projects, they gave grants to public relations companies. To help develop like the branding and the campaign. So it's an actual company that like does this for like if you're a healthcare company or and you want to have a better image for yourself, they'll help you brand it. They'll help you do those things. The company that does that developed this brand for the research program. It was originally called the Precision Medicine Initiative Research Program. And they changed it to the All of Us research program. They wanted to just call it All of Us. Calling it the All of Us research program, our research ethics committee said no, we would not approve it if it was just called All of Us. So it had to be called the All of Us research program because we would not let them call it All of Us. But the reason why it was called that rather than anything about with the word precision medicine, it's because that was part of their branding. They knew what their mission was, which was to get a more representative group. But they figured out this was what they did. Now, did they have really good social science background? I have to say, when I first saw that, I thought, really, you spent like $2 million to call this All of Us? But that really is it. But I will say there's a lot of ways in which it has been very interesting because it's such a large-scale project by U.S. standards. 1 million people. To get 1 million people, and those 1 million people have to turn over their samples for genome for sequencing, their electronic health records, fill out surveys, have measurements. That's a lot of commitment. So to get 1 million people who do all of that, they think they're going to probably have to have 5 or 6 million people somewhat involved to get 1 million full participants. For us, that's such a big scale project that it means they don't call it recruitment anymore, right? So we're used to having as a research ethics committee, we're used to seeing rules for recruitment that, you have to, it's the beginning of the informed consent process is what the rules say. They don't do any of that. And so instead they don't call it recruitment, they call it marketing. They're marketing this to get people to reach these other populations. So calling it the All of Us research program was the All of Us part was the marketing thing. Calling it the research plan was our saying, you can't call it that. So, yeah.
Thank you.
I'm just going to ask a very general question. I remember back in the years when facial recognition was first applied at border protections. Remember I was going to get into Australia, and then obviously it took the facial recognition a bit more time than the guy, a white guy just next to me, right? But it has improved over the years, and now you can wear your glasses, and you don't have to get rid of your glasses, and they can read every one of you. So do you see that trend also in medical data? Because like I saw in the data, 96% was pretty bad and 81 is improving. But do you see that massive trend actually is working and will be more people willing to give their data to your research?
So that 81% is it's interesting. So so Alice Popejoy, who was the first author on that, is now working at my center at Stanford and another center. So Alice had a different figure than that 81%. She just wanted to look at the US studies. If you looked at the US studies, it has gotten better. It's gotten better from 96% to 92 or 93% European. Has not improved a lot. The reason why it shows 81% is because the situation has not gotten better in the US. What's changed is people in China and in Japan are actually doing their own GWAS studies. That's what's changed. It doesn't represent changes in the US. It represents the fact that this research is becoming more internationalized. So at least up until now. I think that will change because of the All of Us research program. If the numbers that they've got so far continue and they do all this sequencing, then we'll at least have a much bigger, richer database that we've ever had before. But I think that took an explicit decision, and it's taken a lot of money to build the kind of connections. When we said to build trust, you have to really work with these communities, that takes work, effort, and money. And this program has a lot of money behind it, and so they're able to do that in a way that most efforts to try and build databases, which are much smaller scale, are unable to do.
I might raise another question that I think I come from artificial intelligence, and I think in healthcare that people trust too much on artificial intelligence in a way that it might have really catastrophic risk that you use this kind of technology. Let's say that when you introduce less than 54% of the noise, and then it could say that, oh, you're not with skin cancer. And now when introducing the noise, and then it says, oh yeah, you are. But actually, for the doctors, they don't really can tell from this kind of, adding this kind of noise. And also, when you rotate the pictures from another angle, in this case, it says, oh yeah, you are. And then when you rotate it back, the image, it says, oh no. So I think the current machine learning models are really not really robust enough to be used in a very steady way to have services worldwide. So I guess I would suggest that in bioethics that we should have more challenges to AI geeks to provide more robust services. And also, I would like to say that considering from the AI for healthcare, it's really also about low and middle income countries that when you have AI services, and now the big step is going really for the rich people to have better life. But for now, what actually could happen is that you could have instant medical doctors that having access to your data or to you real time in those low and middle income countries to help those guys to really get things forward. just some general comments.
Yeah, thank you. About your concerns about AI and the over-reliance on it, I completely agree. I think it is important a little bit to distinguish between predictive analytics, where using predictive analytics today, for the most part, all the problems, the Pittsburgh example, I think there's a lot of reason to be very concerned, but it's still happening, right? So people are still doing this. They're, at Hopkins now, they are binning patients to decide how much dosage of radiation to do based on on a predictive analytic model for outcomes that looked at this data. And they were trying to do something similar at Stanford, but I'll just say they did not have enough African Americans in the population to even apply to large parts of the population. But they are doing this now at Hopkins, and they're implementing it. So, but I think for predictive analytics, I have a lot of concern. For things that are really more diagnostics, for like being able to read images in pathology and radiology and things like that, I think there are a different set of concerns. There are some similar concerns. I think there a lot depends on how of concerns I have there are really about how they're going to wind up being implemented. And I'll just give you one example of something that was designed to do one thing and wound up doing something else. So when radiologists are looking for cancer on images, most of the images do not have cancer. So for every one image that has cancer, there's 99 that don't have them. So they waste a lot of their time looking through, the radiologists spend a lot of wasting their time looking at things that don't have cancer in them. So they thought, what if you had an algorithm that just got rid of the ones where we knew for sure did not have cancer, and then and to save time. So instead of having to look through 100 for that one, maybe they only have to look through 30, right? So it makes sense that would save a lot of time. But you'd want to also be cautious for all the reasons that you were just describing. You wouldn't want to say, let's use that to make the diagnosis and make it a one-to-one, because it's not good enough for that. So you're going to have a robust number of false positives, and so it might be 25 or 30. That's still better than looking at 100, and still could be save time. The problem is, when it came time to the integration with the part of the system that were the physicians, the humans, the physicians were freaked out a little bit about the fact that the machine learning had told them that all of these 30 were positive. And so instead of being able to look at them fairly quickly and see that there's no cancer, they kept spending a lot of time looking at each one because they were nervous about that fact that the machine learning said it was there. And so the result is that even though they had less to look at, they were spending more time on each one of them. And so in net, this thing that was supposed to save time wound up taking more time and didn't work to save time. And that's why I think we really have to look at the end implementation and way it actually is used in a real world situation. Because even with predictive analytics, if you have a predictive analytic and every time the result says one thing and you believe it when it's an African American patient and you don't believe it when it's a white patient, then that could lead to even more exacerbation of problems. And we've really not done very much work yet studying what happens with physicians when they have these tools and start using them. And so we need to do a lot more studying of not just the interests and values embedded in the design, but what happens when it actually winds up getting utilized. Because I think we're going to find a lot of examples like the things where it's like having all kinds of unintended consequences once you have the interaction between a person and an algorithm in all kinds of different complicated ways. And part of that is a function of not understanding the limitations of the algorithm.
I do have an additional question that I think when we use the word artificial intelligence in healthcare, actually we're helping AI guys to sell their ideas in a way that actually what we're doing in healthcare is really data analytics.
Yes.
And automated decision making. By using the word data analytics, things could go wrong. And also for this automated decision making. But when we're talking about artificial intelligence, we think that, well, there could be some magic right there so that you could trust the system. So in that way, I think we're not really going to the right way to bring the current stage of AI to people. Actually, for now, right there, when we are mentioning AI, what what we mean is something that is without intelligence and very problematic. So that's my general comment. I do have a question that, what do you think that...
Sorry, before you ask your question, let me just say, I agree that the language is interesting. I mean, I'm old enough to remember when using algorithms like this and machine learning did not count as artificial intelligence. I remember when artificial intelligence meant expert systems using heuristics, and anything that was more algorithmic did not count. So I do think that the calling it this really did make a big it's part of the sales pitch behind it, and it goes back to that point that language matters. We used to just call them, in the US, we called them bone marrow transplants. Then all of a sudden they became stem cell transplants, right? Because stem cells were hot. Artificial intelligence is hot. Predictive analytics, not so much. So when you use, so I think all of this matters. And it doesn't even often have to be really deep machine learning. I mean, some of the models can just be regression, right? So with just a lot of variables. And so that's not really, how is regression artificial intelligence just because it's using a lot of variables? So anyway, so you can ask your question now.
A counter question would be that when World Health Organization would like to have an AI ethics and governance guideline, let's say, and then says that you should not have gender and racial bias. And I think in this case, when it's signed by different countries, and then what could happen is something like, we totally agree, but we don't really have the money to do it. Let's say that we only have 10% of the data about male, and 90% of them are about female, or the other way around.
Yeah.
So do you have any suggestion? What if that happens, and what should we do?
Well, so two things. So first, the issue about not having enough representation in the data. I think there are things that can be done, and so I think some of our studies which showed building relations, making decisions about that, I think that's solvable. But the issue about whether there can be racial bias avoided in this, I think that's impossible unless you fix society. In a racist society where there are differential outcomes based on race, you are going to have those differences captured in the data, and that means machine learning will capture that if it looks at healthcare outcomes. And so I think what it highlights is we need to fix society's problems, and it's not just and it's race, it's also economic disparities, even in countries that have national health systems. So the UK has a national health system, but they have the exact same health wealth gradient that the US does. So virtually every country that's been looked at, you see similar health wealth gradients that exist and excess death in poor populations. As long as you have that happening, when you learn from it accurately, those biases are those inequalities in society are embedded in the data. And so I just don't think it's possible to do that unless you can fix society first. And that's why I sort of suggested that's partly what we need to do is this is an occasion to really look harder at the truth that we don't want to see of all the excess death occurring in poor populations, in minority populations in some countries.
Do you ever think when it's on application, time is the issue? Because when you have a patient and then you get his information on like DNA levels and protein levels or maybe electrocytomic levels, all these processes take a lot of time, maybe months. But when it's a patient, the first several key months will be very key for him. And if the precision medical process it takes too long, like maybe 6 months, do you think it's actually a practical thing to be used on the on treatments?
So Precision Medicine Initiative is a research program. It is not clinical care. It is not designed to provide clinical care for anybody. It's taking people, it's a database for researchers to develop insights that might later be used by other clinicians in research, in clinical care. But it's a research database. It is not clinical care. And the idea is it's also not supposed to just be a single time snapshot. They're hoping, although this is the one I'm more skeptical about, but they're hoping that this is going to be a 10-year involvement so that everybody who's part of this, they're going to continue to study, they're going to do surveys, they're going to monitor their health records over a 10-year period to produce huge amounts of data about people over time that can then be studied to get results that then can be used to help healthcare later on. That's the vision behind it. So it's okay if that takes 10 years. That's not healthcare. Healthcare is what you're getting when the person's coming into their physician, and that's a different thing. So it's really important to understand that. We were very worried that when people sign up for the precision, that for what's a research program, that they not commit what's sometimes called the therapeutic misconception, that they not believe that they're getting precision health care. They're not. So in the Precision Medicine Initiative research program, and that's all I was talking about today, is not clinical care. It's really about these research repositories that are going to produce those results. That's all about doing research, and it's really important that people who sign up for those repositories do not believe that they're getting health care.
Hi, I'm quite curious about the research you design, the research questions you design about the focus group study. So you compare the difference between the different ethnic groups and ask them, and you contrast their reactions based on their answers. So we are now under the guidance of Professor Tsuyali. We want to know conduct a same questionnaire study to ask people's opinion about health data sharing. But we are but we find problems about how to design the questions to know the people's, to compare the difference. So
yes,
yeah.
Is this going to be a survey?
Mm-hmm. Yes.
So you've already done the qualitative.
Focus or questionnaire survey.
Yes.
I mean, my question is focus group study or questionnaire survey?
So have you already done some focus group data or individual? We usually start with the qualitative studies before we do the quantitative studies to help with the research design. But you may already have a lot of that data.
Before then we do some qualitative interview.
Yeah, I think in general, if you're really asking about the trade-off, is that what you're trying to get to? The trade-off between those issues about data sharing versus privacy or consent, and you're getting those trade-off issues. So I'm going to talk more about that tomorrow because we studied that in a different study where we looked at comparative effectiveness research. That is a hard thing to study. And the way that you ask it, so I would say there's 3 or 4 different design methodologies worth looking at. One design methodology would be to try and really get them to elicit their revealed as opposed to stated preferences. Like the study that we did that I'm going to talk about tomorrow, we got people to give their stated preferences. That is, we gave them, we asked, if you could not do this research, would you be willing to drop the consent form as a way of seeing the standards, as a way of seeing them to see those trade-offs. But there are ways of actually getting to the revealed preferences by actually giving them different scenarios and seeing how they react to different fact patterns. So for example, you could vary this a bit depending on how big your survey population is. I think it's easy to get a little go overboard. So some other researchers who've been working at the same time we've been working on that, they did something where they had 32 variations, and so they needed a large number to be able to get these studies off the ground. But I would say that design realistic scenarios. So for example, this will have the highest level of, let's just say privacy is the thing you're trading off. This will have the highest level of privacy. that will allow you to do some particular study for something that's important. Let's just say, I don't know, pick a disease that you think is really important. Hypertension, or that would be at least a big disease in the US, say, or diabetes or some other disease. So you pick the disease, but then you say, doing this will offer for the highest protection and privacy for the people involved. However, the results will not be discovered or proven. It will take 3 more years to figure that out, and during those 3 years, this many people will die from the disease that would otherwise not have died. So, and then see which would you choose, and give them real choices. Like you have to make this decision, and see what decision that they really make and opt into. And there's lots of different study design methods for getting at it, but they're all challenging. And the other challenging thing, this is one of the reasons why we started developing these videos in the first place. You have what we call, this will not translate at all, we have what our research team calls the Emily Latella problem. So there was a TV show in America called there is a TV show in Saturday Night Live called Saturday Night Live. It was a very popular comedy show. And a long time ago, there was a character on Saturday Night Live where a woman would get up to do an editorial and would start saying things where she got things wrong. Like she would get up and she would say, "What's all this talk about euthanasia? What about the youth in America? Why are we talking about the euthanasia?" And then someone would say, "No, euthanasia." Say, "Oh, never mind." Or, "What's all this talk about the death penalty? Don't deaf people have enough problems without a penalty?" Anyway, so she would get things wrong. But this is one of the problems if you're studying the attitudes of the public. If they fundamentally don't have understanding and are misunderstanding things, it just doesn't tell you very much to do a survey of people when they're wrong about fundamentals. And we found in our earlier work, which I'm going to talk about tomorrow, about comparative effectiveness research, this was especially a problem because people have all kinds of false views about their doctors, about their health care, about what their doctors know and what the basis of their decisions are. And if the starting point is wrong, then they won't understand the trade-offs and the questions you're getting at sufficiently. And that means any study you do has to fix that problem. So we actually designed our videos and comics and other things that we've done to try and educate people in a way that was fast enough to actually get embedded in surveys so that we could actually do those kinds of studies. The value study videos I talked about today, we didn't use those in the survey. We only use those in the focus groups. But the things I'm going to talk about tomorrow, we actually embedded these videos in the actual surveys that we did so that they would actually have to know something about, and to disabuse them of the emotion. Because if you talk to most patients, they believe their doctor is creating treatments just for them, based on what's best for them, without realizing that if I go to this doctor and I have hypertension, they're going to give me drug A. If I go to that doctor with hypertension, they're going to give me drug B. If I go to this doctor, they're going to give me drug C. And they're all good, but we don't know which is best. And in order to be able to talk about comparative effectiveness between all approved drugs where we don't know which one's better, you have to really get that across. And that can be very hard. And doing that, we also uncovered a lot of misconceptions and misunderstandings. Patients would say, no, if it's a trial, then one of the things has to be new. That's not proven. It's like, well, that's not true. And it took a real work. And people still kept making mistakes, even with our videos.
So, any other questions? So if no question, then I have a question. In the last two slides, in your solutions, the first recommendation that you recommended is need for as much transparency as possible in algorithm design, right? I know transparency is very difficult, and I mean, of course, we know it needs transparency, but how to solve this problem?
Yeah, I think this science paper is a great example of that, though. I really am worried about turning over the algorithm process to commercial entities and having third-party vendors be the ones who are developing this outside of the healthcare systems and then selling it to providers, selling it to physicians, selling it to healthcare systems. I think that is going to be a recipe for disaster. And part of the things that you were talking about before, those are going to be much worse if those are being developed that way. So I think as much as possible, we need this design process to happen as part of a shared public process so that people can get access to those things. I don't know how it's happening in China. Are you having commercial type entities doing a lot of this design work, or is this being done under public auspices?
That's my question coming up there. I saw an interview by a UN body also. There were, a lot of people are talking about AI for good. And this, I can't remember his name, sorry. But his total view was that we should actually unify the corporates and governments and different organizations to have this data, because this data are good data for people's health.
Completely agree with that. That's mostly what I'm going to be talking about tomorrow. But I completely agree with that point about the data being used for good. But I worry about the people, but a lot hinges on who's using it and making sure that the actors who we entrust, so this is part of an entrustment model, right? Who is going to be a good steward of these public goods and make good use of it? Is it a public entity? Is it an academic entity? I trust academic entities. Now, they're not perfect, but by and large, I have more trust in public entities than I do in the commercial ones.
But then in China, Tencent is developing these.
See, that's just exactly the same, right? In the U.S., it's Google, it's Facebook, it's Amazon, it's these big giant companies. If these big giant companies in China and the U.S. are the ones who are really going to develop this, then there's not going to be transparency, and we're not going to be able to unlock these things. So I'm very, very worried and concerned about a world where, these large corporations are going to really have control over everything.
So need to establish a separate something like a peer review committee or panel to evolve to.
I don't think that works. I think the work of needing to really the people who really got into this algorithm, what we really need, in a way, this is part of the same idea behind data sharing. So there's a big move, a concern about the replicability crisis in the sciences, that large numbers of studies can't be replicated, and part of it has to do with a lot of p-hacking and a lot of things that are going on in research. And so there's been a big push to make data more public and make data available so that different researchers can access that. Well, that's got to be not just true of data, it's got to be true of the algorithm design process. When you have an algorithm that you want to use for something like this, you need to make the decisions that were made transparent for why you chose this rather than that. This is why we chose this variable. This is why we chose this population. This is why we chose this to be our training data. This is, there's a lot of choices that get made in the design process. Those need to be made public in the same way that data needs to be made public.
Yeah, so that means finally we have to depend on the community of the algorithm designers. They're self-disciplinary. That means have to rely on them self-disciplinary.
Yeah, the problem is if they're working for Google or if they're working for Tencent, that's not going to happen. So I'm very worried about that.
That's a real word. Yeah.
Okay, I think time is up,
Yes.
and we have to stop here. Thank you, Professor Magnus, again for the great talk, and for all the audience for this interesting and stimulating discussion. Thank you.
Thank you.